Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals with me, Catherine Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While NICU parent scars are not as visible, NICU parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all, and welcome back to the podcast. It's another great episode of NICU Heroes, I have no doubt. We have had some great guests talking about ROP. We've talked about child life. We've talked about new innovations that are happening, new research that's happening in NICUs. And today we're going to focus on trauma, and particularly somatic trauma therapy. While I think most of us can agree that we have seen a great influx and attention drawn to mental health, I don't know that we've heard as much about somatic trauma therapy. And so we're definitely going to talk about that. I mean, I think we can all agree. I don't think that this is just me talking. I think that we can all agree that every NICU, no matter how amazing it is still filled with trauma. That you have patients and moms and dads coming in who maybe had pre-existing trauma, and then you add a NICU stay and it becomes even more difficult for them to be in that place. So as a NICU professional, I really felt strongly to give you some good tools on how you could better understand your patients, maybe understand what their responses are or why they're reacting in a certain way, and then how you can help lead them towards healing by giving them some good, I think, actionable skills that you're teaching them. I remember learning some amazing things from my NICU nurses, and I did not realize how valuable they were until months and even in some cases years later. And I remember thinking, oh yeah, I learned that in the NICU, particularly from a NICU nurse. So my guest today is a somatic trauma therapist, and I think that she's going to give you some great insight into what is that kind of therapy and how can it benefit your patients. My guest today is Parijat Deshpande. She is an author, speaker, and the CEO of a global boutique company dedicated to reducing pregnancy complications and ending preterm birth. She's on a mission to end the high-risk pregnancy crisis, and she has served and supported hundreds of women through her programs, her one-on-one work, and her best-selling book, Pregnancy Brain, a mind-body approach to stress management during a high-risk pregnancy. And so with that, let's chat. Well, I am honored and thrilled to have someone that I've had on our other podcast for NICU parents and caregivers. But today, this one's just for NICU professionals. So Parijat Deshpande is my guest today. And Parijat, I'm so grateful that you're back. Thank you.
I'm so grateful you asked me back. Thank you. I'm so looking forward to this conversation.
Yeah, I mean, we definitely had a lot to talk about in the last episode, and we only had 30 minutes. And I was like, now we have an hour, so we have a lot more to talk about. So let's start with the big thing, because I think that somatic trauma may be new terminology. So what is it, and how does it differ from what people would consider traditional therapy?
Sure. So let's start with just the idea of what traumatic stress is. And that is the idea that our body goes into a threat response and it never comes out of it, is the really simplistic way of describing trauma. And that's why I think somatic approaches to addressing trauma really get to the root of what traumatic stress really is and what we can do about it to help people kind of work through and move through that cycle. So somatic, you might hear it described in 2 different ways. Somatic trauma therapy is kind of the pathogenic approach to addressing trauma. And what I mean by that is it's modeled after the existing systems of assessing, diagnosing, and treating disorders. And so you'll see under the umbrella of somatic therapy, there's a lot of different types of somatic therapies. There's a lot of different modalities of that. And the intention of those modalities is to treat disorders versus A salutogenic approach is where you're basically teaching somatic skills to help complete the threat cycle. So you're not actually diagnosing, assessing, or treating anything, because you're coming at it from a perspective of there's nothing actually wrong. It's just that cycle didn't get to complete. And so there's kind of a depathologizing approach, which I really appreciate. So somatic trauma therapy, very large umbrella. We've got two different sub-umbrellas under that, the pathogenic approach, the salutogenic approach, and underneath those are various different modalities of how to practice those different approaches. Now, that's different than traditional psychotherapy, which is talk-based. It is thought-based. It is behavior-based. It's emotion-based. It's the idea that if we can talk through what's going on, we can come to some type of resolution. If we can put words to our emotion, if we can adjust our behaviors, if we can put a narrative or a story to our experiences, then we can move through. What we know, so I'll say this first, that is how I was originally trained. So there's no shade coming from this. That is how I was originally trained. We also now know that that is an outdated model for addressing traumatic stress. So I tend to now encourage people to really look at what type of somatic approaches they want to address first, and then move to the older model afterwards. Because when we can allow our body to complete those cycles, then we're in a much better, more appropriate physiological state to then put a narrative to what we've experienced.
So you're saying that they're more like complementary as opposed to opposing.
Exactly. Okay. Yes, exactly. And there's a timing to it. If we can start in the body first, we get our body shifted to a place where then we have access to the cognitive faculties to be able to put narrative and story and words to our experiences. That's a totally different approach and a much more effective approach, I find, to resolving the traumatic stress than if we go straight into the talk therapy typically, which I was trained in, which is what we tend to expect to do at first.
So like the receptivity is greater because you've addressed this one thing first, and then it's sort of like you've opened the well and you're like, okay, now we can do what we're used to doing, as opposed to doing the outdated model in the sense that we keep doing it and we're getting the same results. Like things aren't, the cycle we keep circling back. I think that's what I'm hearing. Yeah.
Yes, exactly. And when we understand traumatic stress, just from a physiological perspective, we know that blood flow moves away from those parts of the brain that allow us to be introspective, to put language to our experiences, to be able to create a narrative about what did I go through and what is that story. It's not to say we can't do it. It's that it takes a lot of energy to override those natural processes, those biological processes that change. When we can shift our physiology first from a somatic perspective, then the blood flow goes back to all that. And so it's a lot easier. You get results faster. You are in a body that is able to participate in that much more effectively than before.
Well, and that explains why when you go through something traumatic and someone asks you about it, you have a really hard time articulating what happened, how to process it, and then how to heal from it, because that all makes sense.
Yeah.
Okay, I'm so glad I had you. This makes so much more sense.
Oh, good.
So I know you were talking about the way that you were originally trained. So I know that you had an experience, Parijat. Can you explain, like, what is it that sort of caused you to say, I think this is an area that I want to practice and really dive into because I see the benefits? What was it that shifted? What led you to do this particular kind of therapy?
Absolutely. So I will point to two specific moments. One was where it opened the door to recognizing I want to go into the somatic world and move away from the clinical training that I had already had, not ignored entirely, but take it and shift it and morph it into something that I thought was a little more appropriate for high-risk pregnancies. And the second point was when I realized I wanted to move out of the pathogenic model into the salutogenic model. So how I found there was, I think, two main points. First was I was about 14-ish week, 14, 15 weeks pregnant. I was on bed rest for multiple weeks by that point. I'd already developed multiple complications by that point.
Wow.
My life that had been full with work and social engagements and weddings and birthdays and, all these things had shrunk down to you can walk up the stairs once a day. And it was so hard. And this was after I'd already experienced a life-threatening loss. And so I was going into this pregnancy already terrified of something happening to me, something happening to this baby. And I remember very distinctly this moment around that 14, 15, 16 week mark. I was at home by myself and I'm sitting there, I'm going, I am so scared. I'm so anxious all the time. And my head went to, well, my clinical training, I know what to do about this. And now as the patient, I'm like, I don't need any of that because my thoughts aren't the problem. There's nothing wrong with my anxiety. How can we pathologize something that makes perfect sense? How can we tell a birthing person or a pregnant person, don't be scared that you're going to lose your baby after you've already lost one, after your life had already been threatened, after you have diagnoses for pregnancy complications. I think that's ludicrous to even have that expectation. So my head already started going to, I don't like the pathologizing approach to pregnancy anxiety that I have been trained in so far. Fast forward about 8 weeks or so, at 22 weeks and 4 days, I landed in the hospital, 3 centimeters dilated, and my entire team was preparing us to lose the baby. They said, we're going to give you medication, but I think you've got about 72 hours, and you're probably going to deliver within those 72 hours, and it's probably too early, and he's not going to make it. And I remember thinking, as I think most parents at some point do, they just go, I'm going to try whatever at this point. We're at the very end of the rope here. And so I had this impulse just internally of, I think there's something body-based that's going on here that is affecting my preterm contractions. And so I consented to all medications and all medical interventions. And then I told them I want to try something on my own to see if I can stop the contractions. Obviously, in that state, no medical provider is going to say no to that. So they, patted me on the head, said, sure, go for it. And what I recognized was that I was in a posture that was protective, right? Tight, trying to hold the baby in, trying to keep myself braced. And anytime I was in that posture, even though I was in Trendelenburg, so head below feet and very uncomfortable on medications, that posture was just automatically there. And anytime I was in that posture, the preterm contractions picked up and you could see it on the monitors. And anytime I allowed myself to come out of that posture, they stopped. And you could see it every single time on the monitors. The nurses even noticed that this was happening. I still remember a moment where a nurse came in, she was like fascinated by what was happening. And I was like, watch. And I don't know what state of mind I was in, but I'm like, let's try this. And so I did it intentionally. Contractions picked up. And then I did what I needed to do somatically to come out of that. They completely stopped, totally in real time. And that was the point when I went, okay, I'm out of the pathogenic model. I want to go to salutogenic. And now I understand that there's something somatic happening here that is actually affecting the health of the pregnancy right now. And what if we could teach people how to do this before they get into the moment that I'm in, which is at the end of the road, going just,
at the last possible minute. Like, let's see if we can address it before.
Exactly. They gave me 72 hours and I was able to help myself stay pregnant for 15 days. And that was the moment when I went, there's something here. And I made a vow to my son 2 days before he was born. If we both survive this, I'm going to leave my career and I'm going to switch it up. I'm going to come back and teach people how to do this for themselves because I do not have any superpowers. I am nobody special. If I can do this, anyone can do this. And that needs to be available to everybody. And that's how that whole package came together to the work that I do now.
You know what I think is fascinating, and this is a recurring theme with, I think, almost all of my guests, is that we had either a certain path or we had a certain idea, and it was our babies that opened doors that we thought previously could never
Yeah.
be opened, or that maybe we didn't even know that existed. And so I find it interesting that the smallest person gets our attention in the biggest way.
Isn't
Um,
that true? I love that.
yeah, yeah. Um, all right. So let's talk. I know you talked about this cycle. So we've been hearing you talk about the cycle. So let's dive into that a little bit. So, what is a somatic trauma therapy cycle? Um, and how does a woman who's like, I know you mentioned enduring like a high risk pregnancy, how does a woman sort of move through that particular cycle?
Absolutely. So if you don't mind, I'll offer a slightly different way of conceptualizing that, which is what we're talking about is a threat cycle.
Yeah.
And another way of saying that is a stress cycle. So when we talk about stress, it's not an emotional experience. It is actually a physiological change that happens in the body that actually works cyclically. And what we do with somatic work, whether you're following the pathogenic model or the salutogenic model, in somatic work, the intention, part of the work is to complete that stress cycle. So when we talk about traumatic stress, as we talked about at the beginning, that's when the cycle doesn't complete. So even though I was doing all of this for myself on hospital bed rest in those final days, those cycles didn't complete as well for me as they could have. But really where the cycles got stuck for me was in the NICU. So when I look back and if I would describe, what was the most traumatic experience of my high risk pregnancy or my NICU stay, it would be my NICU stay. Because while I was so focused on the somatic work on hospital bed rest, it went out the window when I met my child and I went, oh my gosh,
Yeah.
what world is this now? This is okay. And that's because those cycles got stuck. So what do we mean by that? I like to describe it. If you read my book, you'll see I describe it as a bear chase frequently. So here, let's talk about it a little bit differently, just so you have two examples. Let's think about an almost car accident, right? So you are driving down the road, and let's say we'll say it's the perfect day. So you're feeling great, you're happy, you're not rushing anywhere, the weather is wonderful. You can hear the music on the radio. You're chilling and you're driving. Everything's fine. And then from the corner of your eye, you see a car coming, starting to encroach into your lane. And you know that if they keep going, they're going to hit you. What happens, right? Brain shuts off. Thoughts are too slow to understand what's happening here. What happens instead is your nervous system assesses that, recognizes there's a potential danger, and does whatever we need to do in our bodies to actually change our movement, our posture, our sensory system, the way we understand and take in our environment, the way that we take in and don't take in our internal environment to keep us alive in that moment. So if we were to say, if this were a movie and we went down to like 0.5x speed, what we would see happen is our eyes would get wide, our field of vision would narrow, our hands would grip the steering wheel, our heart rate would shoot up, our breathing would shoot up, our posture would change to brace for impact, and we would make whatever quick movement we needed to swerve out of the way, right? We've all kind of been in a similar situation to this. It happens in nanoseconds, but that's really what's happening here. That's the beginning part of the cycle, right? The threat is assessed. We're now in that mode. And now everything that we do in our bodies, from every single system changing to support survival, now allows us to survive that moment, right? When we swerve out of the way, then typically what we expect to happen is we swerve out of the way, maybe we honk, somebody honks, something happens, and then we get back into our lane. And then again, 0.5x speed, here we go. What do we see happen? First, we recognize, whoa, my heart's racing. It's not a thought. You feel it, right?
Right.
Really hot, right? I'm to turn the AC up. Oh my gosh, I'm gripping my steering wheel. So I let go a little bit. Hands are super clammy. Wow. And then we hear the music that's been playing the whole time that we had stopped hearing before. And then we turn to the person in the passenger seat and go, can you believe that guy? He almost hit us. Language came last. Sensory work, senses came back on second to last. We noticed our body and our posture starting to unravel a little bit. We're no longer bracing, we're relaxing into it a little bit. That's when we notice the internal environment. We notice our external environment, right? There's a very predictable way that unfolds. That is the completion of the stress cycle, that threat cycle. Traumatic stress is when we are frozen in the bracing moment, right? That we are at the top of that peak when we think we are about our safety and our survival is threatened. Our bodies have changed to protect us, to help us survive, and we never come out of that. And that's not to say we never will come out of it. It's just we haven't yet.
So we live like in this constant, I think certainly if you're a NICU mom listening to this, but I mean, I think, and that's the way that the NICU is. It's not
Yes.
designed to be that way. And it's designed to help people, but also you get bad news like it feels like every day, every moment. So you're always bracing for the next impact. That makes complete sense.
That's right. And you think about the environment of the NICU too. The beeping is always there. It's
Right?
loud. It's not a peaceful place to be.
No.
By any means, no matter how wonderful the NICU nurses are to try and help you
Right.
turn it into a home, the external environment is there to elicit emergency. You're
Right.
looking at a child who shouldn't necessarily be born yet if they were born preterm, or if they were born full term, they're there and they shouldn't be there, shouldn't with quotes,
Sure.
because something's going on, right? And so you're not there for fun. You're not there because, oh, we just need a little bit of extra monitoring necessarily. The people who really leave the NICU with traumatic stress are there because those emergency experiences, those threats are relentless. They're constant, and there isn't time to complete those cycles. There isn't an opportunity to do that. Or even if there is, you're right back up there so quickly because something else is going on.
Something else. Yeah.
Your child, something else in the environment. It's always there. Absolutely.
So if you're in the NICU, Parijat, and you're working with someone who's in a high risk pregnancy, it's likely that they're going to be in the NICU. How do you help them as they're moving through the cycle? How do you help them when they're in that perpetual state of bracing and not to stay there? Like how to move out of that, whether they're currently in the NICU, maybe it's a long stay, or maybe they're discharged and they have follow-up appointments. Like how do you get out of that? How do you move past
Absolutely.
this really difficult bracing kind of feeling all the time?
Totally. So I heard two questions in there. Is what do we do with pregnant people who are expecting to be in the NICU? And then what do we do in the NICU? And those are actually two different answers. So for pregnant people, I actually don't work with them when they're as close as I was to the NICU, because there's only so much that we can actually do. And it's really short-term support. And so that's why we start working together pre-pregnancy to start practicing outside of pregnancy. What is it like to complete the threat cycles? Because pregnancy in and of itself, for my clients who've already delivered preterm, already been in the NICU, already had losses, that in and of itself is a threat. And so
Sure.
we have to practice outside of that first. And the reason I say that is because during pregnancy, it's very difficult to learn a new skill when you're in the middle of a threat, right? Like if I'm about to avoid a car accident, that is not the time for me to learn how to play the piano. Like it won't register, right? Nothing in my brain, my body is not in a place to be able to learn that. And so that's why it's so important to start this work, just like any other part of your prenatal care, where you begin vitamins before you try to conceive, you go and do your preconception appointments before you try to conceive. This is the work that you really want to start ahead of time. And then sometimes I do get inquiries from people who are in the NICU going, help, right? One of the things that I am very adamant about is that yes, the NICU is a place of constant emergencies, constant threats. And that's not going to change because, as we talked about, and I don't mean this facetiously, you're not there for fun. You're not there to just like chill out and let somebody else take care of your baby. You're concerned, you're worried. Sometimes you're actually fighting for your child's life. And so the goal there is not actually to help manage the traumatic stress necessarily, but instead it is to go, how can we use the survival energy? And by energy, I mean all the physiological changes that happen to put us in that bracing position. How do we use that to keep you moving? Because what we don't want is for you to freeze.
Frozen.
We don't
Yeah.
actually want you to freeze up, because that's what locks kind of that survival stress in. And so we do a lot of work about, I'm not going to teach you how to calm down. I'm not going to teach you how to not be anxious. You're worried about your child, right? This is, again, that salutogenic approach coming back
Feel
in.
what you're going to feel, right?
It's fine. But now let's see what you're feeling, that anxiety, that fear. Where is it? And how is that trying to clue you in as to how your body needs to move? In the car accident example, my body is gripping the steering wheel. And if you actually really paid attention, you'll feel a lot of tension in your arms, in your fingers, in your shoulders, and less so in the bottom half of your body, because what you need to do is swerve out of the way. There's a very particular movement that your body is trying to get you to make. I'll give you an example of that. And how some of that traumatic stress was stored in my body was when my son was born at 24 weeks and 5 days. He was too little and too medically vulnerable for me to touch him even. And so he's on the oscillator ventilator, and I just wanted to grab him and hold him and just be like, it's okay, I'm here. And they're like, not right now, don't touch him. And what my body wanted to do was reach out. And what they're telling me to do is hold back. And so I had a lot of this trapped survival stress in my shoulders and arms and my hands, because I wasn't allowed to move in the way that I wanted to. If I'd worked with myself back then, we would have done a lot of some of these types of upper body movement practices, so that, sure, you may not be able to hold your child, but that survival energy needs to go somewhere. Your body needs to move in a very particular way. How can we mimic that to the best of our ability so it doesn't stay stuck inside?
Makes sense. Well, I certainly, I mean, as I'm listening to that, I'm also realizing that, let's talk for a moment about access, because I know that there are some women who access, whether it be prenatally or even in the NICU support wise, that they have the things that they need to move through those cycles, two, to even know that those resources are available. Um, and then you have women who don't have those things. Maybe they don't have support. Maybe their age is, their ethnicity, many factors may be a reason for that. I know that working with women in the BIPOC community is a big goal of yours. It's a big thrust. Do you find, Parijat, that the trauma is greater if there's a woman of color going through this versus a woman who's not? Do you
I
see a
do.
difference there?
I do see a difference there. And I think the biggest difference is two-factor. One is that a lot of my BIPOC clients come in with traumatic stress that wasn't related to their reproductive history
Right.
because of their ethnic identity, their racial identity in the world that we live in now. And that is compounded with the added risk of medical trauma that they experience, both outside of and inclusive of their reproductive history. They have a much higher rate of experiences where they say, this doctor didn't believe me, and then this happened. I tried to get their attention. This didn't work. They didn't do anything. And then I was left in pain for XYZ number of weeks and months. Those two usually compound each other. And then if they've also experienced pregnancy complications, losses, preterm delivery, NICU stays, all of that compounded together, I think is a much more significant impact. And it's much more common, I'm finding, with my BIPOC clients than with my non-BIPOC clients.
Right. Well, and I don't think you can discount that there are many kinds of trauma. I mean, we're specifically focusing on pregnancy and related trauma, but we are imperfect people who have various life experiences, and we've all experienced trauma in some way. And so when you add unresolved trauma from various factors, and then you have a traumatic, birth or stressful NICU stay, so you're just layering one right on top of the other, it can be a lot.
Yeah.
What are you seeing? Like, do you do different things with your BIPOC clients than you do with those who are not BIPOC clients? Or is there just a general awareness of like, I'm more aware of what it is that you come to me with than other people?
I think it's a little bit of both. There's definitely a lot more discussion about the pre-conception phase, the even before I was ready to try to conceive phase. You know, there's a lot more awareness like my BIPOC clients bring in to say, you know, these traumatic experiences have happened to me even before that in my mid 20s, my adolescence, you know, childhood. There's a little bit more awareness. Whereas with my non-BIPOC clients, sometimes we uncover that a little bit later in our work. And sometimes we don't even uncover that at all. And I think there's a lot more mistrust in the medical system with my BIPOC clients. So the work that I do is not just somatic work. That's one of three things that we do together. The second of those three is helping them navigate the medical system in a system that they don't trust and that is often essentially built to be harmful in some ways to people who identify as BIPOC. And so how do you do that? Because I work with, you know, clients where you have to birth at a hospital, like birthing centers, home births are
Right.
not
Yeah.
options for them. Midwifery care is not necessarily options.
There's no home care NICU. It doesn't work that
right.
way.
Exactly. Exactly.
Neonatologists don't make house calls.
Not really, not yet.
Yeah. Yeah.
Yeah. And so there's a lot of that. How, you know, it's not just the health-based somatic work that we're doing, but also the somatic work to help them be able to get the care that they deserve and that they're looking for. How do you rebuild your team? How do you find the right people? How do you ask questions? What do you do when you freeze up in an appointment and how do you not do that? That happens, I think, far more frequently with my BIPOC clients than my non-BIPOC clients.
No, that makes sense. One of the things that you mentioned on your website, which I was grateful that you mentioned it, is that you said that um, you want to know that women are not at the mercy of statistics. Speaking of statistics, that they're not at the mercy of that. So I know that sometimes when we find ourselves in a NICU setting or something that's really overwhelming or stimulating, certainly out of our normal routine, um, that you find that you don't want to be a statistic. So when a woman comes to you and says, "Hey, like, I remember my husband and I doing this whenever we went to counseling. We like told our counselor, like, hey, we know the statistics and we're trying to beat them. So how do we do that? So when a woman comes to you and says, hey, Parijat, I know the statistics and I want to beat them. How do I do that? What's sort of the first thing that you do to help them not be a statistic, or at least on the bad end of that, but on the positive end of that?
Sure. I think the first thing that I do once we start working together is to completely believe them and say, it's
Mm,
possible. It is possible. We don't have a magic wand. We don't have a crystal ball. I can't tell you exactly how or what, or, you know, are you going to beat it by a day? Are you going to beat it by 1% or completely? I don't know. But that's not what they're asking for. They want hope. As did I, right? We went through the same thing. We just go, I don't want to be that number. I don't want that to be what we experience. And I completely and wholeheartedly believe them. And I let it sit like that just for a moment. Because I can believe it all I want. They have to believe it with every cell of their body. And when they can do that, then there's so much we can do to support their health and rebuild their health care and really support their pregnancy to stack the deck in their favor. That's really the best that we can do. And we make sure that we have all those pieces aligned to the best of our ability to what is realistically possible for them to help keep that in mind. And a lot of what we do is really lock in that sense of hope physically so that it's not a thought. It's not some fleeting emotion that comes and goes. And today I'm having a bad day and now I can't feel it anymore. We find these what are called somatic anchors. And we go, what does that hope really feel like here? And how can you access that no matter what is going on? Because if you want to beat those odds and you think it's possible, I'm right here with you. I believe it's possible for you too.
that touched on something when you said that. Isn't that sort of the crux of what when we approach a pregnancy, is that we want someone to believe us,
Yeah.
that we have instinct as women, and then when we share that concern with either our NICU nurse or our doctor or a specialist or an OB-GYN or even our partner to say, like, I just need someone to believe me that what I'm feeling is valid, but also that if I want a better outcome, I think it's the belief that can make the difference. I mean, I'm not a doctor, but I certainly believe that that has to play a major role in just feeling, that you're seen, known, and loved in that particular space, and that someone is your advocate. That you don't always have to be the advocate for yourself. It's nice to know that someone else is out there. Um, so when you work with clients, Parijat, do you typically just work with, the woman who's giving birth? Do you work with her partner? How do you find when you work through that somatic trauma? Because I know that we all have, outside influences. Some people, their circles of support are bigger than others, but when you approach a specific client, are you looking at them specifically, or are you sort of looking at the concentric circles that surround them?
So, primarily, my work is with the pregnant person or the soon to be pregnant person. My program, Path to Baby, does include partner support if they have a partner. If they don't have a partner, it's their like next closest ally or whoever they want to bring in. So far, I've worked with people who have partners, and most of them have been male partners. And this is where it's such a validation of how powerful somatic work is, because especially for those male partners, there's such easy buy-in when I tell them, we're not going to talk about how you're feeling. We're not going to talk about that. But
They're
instead,
probably
hey,
like, "Praise the Lord."
exactly. And they're surprised by how practical the practices are, and how physical and movement based it can be,
Right,
and how logical it is, right? That we're not piecing together, well, things that don't are kind of amorphous and don't quite make sense how they fit together, but it's very much, what are you presenting me with? Here's my guess as to what's happening and what I think your body needs. Does that make sense to you? If they say yes, I offer a practice, and they go do it right there, and then they feel
right.
relief very quickly, and they get that kind of that circle that oh, this is actually working, right? They get that feedback loop started really early. And I love that. I love that so much. And then what I found, which was not intentional on my part, but it's that my clients will then teach some of these things to I've heard it, like I taught my mom this. She had her doctor's appointment, or she was worried about me and my doctor's appointment. And I taught my mom this thing. My favorite so far has been that now my clients are teaching their children how to do this.
Right.
And I got a message not too long ago from a former client who has a 2-year-old, and they're getting ready for their 2-year-old vaccines. This kid, at 2 is like
Yeah. No,
wary of
thank
all
you.
the people, and
Right.
right. And she was practicing some of these things from 2 years prior, teaching her child. And this kid was totally ready for that appointment. And her pediatrician even commented, "Oh, I've never seen a 2-year-old actually be able to do this." And they had a conversation about the work that we had done 2 years prior. So it's not necessarily built in that way in the
Right.
program, but the ripple effects of this are so real and go so far, once people can, I think, experience for themselves how simple it can be to support your body in a way to complete these threat cycles and actually feel safe in your body and in your environment.
Yeah, I mean, I'm thinking, I think it was a month ago, we just had our podcast, we were talking about child life and sort of what they do in the NICU, and I remember telling her, I said, "Yeah, there were some things that I learned as watching child life specialists work with our baby in the NICU, and then fast forward 4 or 5 years later when we're doing blood draws, and I think it became instinctual, like, I don't think that I was
Yes.
thinking, 'Oh, I'm gonna go back to the time that I was in the hospital.'" It just became, and I remember the phlebotomist looking at me and saying, how did you know how to
Yeah.
do that?" And I said, "I guess I've been practicing for the last 5 years, and it's become such a natural part of," and so I'm hearing some of that is that when you start to retrain your body how to respond or how to be in a stressful or a traumatic situation, and what do you do, that after you practice it a while, it becomes a habit, so
That's
much
right.
so that it becomes instinctual, meaning that we can change how we respond, how we act based on good healthy habits, and then it becomes almost second nature as we find ourselves in a new situation and applying it in very different situations. I mean, I haven't been back in the NICU since then, but I have been in a lot of doctors' offices. So I love that you mentioned that because I'm hopeful that it may give, those who are listening some hope that as you start to practice it, it becomes natural. as opposed
Yes,
to this weird thing that you do, but instead, and not only that, it works. Um,
exactly.
yeah.
Exactly.
So what do you tell Parijat your clients when you're talking about advocating for themselves, whether they're in like their prenatal appointments or whether they are in the NICU and advocating for what it is that they need for themselves, and then maybe how do they advocate what it is that their baby may need, and that particular probably more on the NICU side. What do you counsel them with when it comes to being an advocate for either moving through the cycles or at least stabilizing so that they don't do more harm than good?
Absolutely. I think for advocating, I've found over the years that number one, we've got to start with a team that's willing to listen and believe.
Yeah.
Because I think where a lot of my clients come to me in frustration is I tried to get their attention. I told them, I have emails and they'll show me just threads and threads of emails. Something's wrong, something's not right. And this is, from the pregnancy side. But I tried to get their attention and they didn't listen. And so this is why, the second leg of the work that I do is so much about building the right team. Is it doesn't matter what kind of team you have and how much you talk and speak up for yourself if they're not listening. So we need to build a team that listens, and that's part of also the reason why I do so many professional trainings. Is you can be as compassionate as you want, but there's a very specific way to listen from a trauma sensitive perspective that I'm hoping more people will learn how to do. And so we have to build that team first. And that's really where a lot of our work starts. Do you have that team? In the NICU, it's a little bit harder because
Right.
you're in the unit, you have
You
very
don't get to choose
limited.
your team as much.
Right,
Yeah.
exactly. And so that's where a lot of kind of twofold, a lot of my NICU trainings come into play, which is not helpful in the acute situation necessarily, but kind of bigger picture is how do we train NICU professionals to listen from that trauma sensitive place. But from the patient or the parent perspective, it is how to talk to these professionals, how to kind of lead these conversations with, this is what I need from you. When's the right time to do that? It's interesting, actually. I draw a lot of that from my couples therapy world from many years ago of, how can we have this conversation in a way that I get what I need? And
Yep.
and that gives them, the professionals, also an opportunity to go, I can't have this conversation right now.
Mhm.
Let's circle back in 2 hours. Right. And now there's no waiting. There's no anticipation. There's no anxiety of they're not listening to me. And when do I get this? And on the provider side too, is now they're aware, okay, something's coming and I need to figure out on my end how to have this conversation with this parent. And I think that it really has to start there. After that, then we can talk about how do you speak up and what do you say and how do you ask questions so that you get the answers that you're looking for at the time that you're looking for them. And then beyond that is then the physiological work of what do you do when they say we don't know or here's some bad news. And that's kind of the third layer, if you will, to that.
Right. No, I mean, I'm thinking of a time that I remember looking at a doctor, and I think it was just because I had good counsel from my NICU nurses, is that I looked at him and I said, "I don't think that you're hearing what I'm concerned about.
Yeah.
I think that I'm not doubting your degrees or your wisdom or your experience, but I'm the mom and nobody, no matter how much medicine you study, knows my baby better than I do. So let's try this again." But I didn't learn how to do that had it not been for my NICU nurses to say, like, they would always ask, "Catherine, do you understand what they just said? Like, do you have other questions?" And sort of like, I remember the doctors would leave and then the NICU nurse would come in and she'd be like, "Okay, how can I help? What did I," and I remember thinking, at the time, I remember thinking I was grateful for that, but I think many months and years later, I was really grateful for that because it taught me how to question people that normally we see as authority figures, but I wasn't necessarily contesting their authority. I was just being curious. I just didn't understand, and that was such a gift that my NICU nurses gave me was, "Are you sure you get it?" So I'm really grateful that you mentioned that. Okay, so now I have a two-part question for you. So, and I'm one of these, and it sounds like you are too, is that I had a birth after, uh, a NICU stay. In your case, you had a birth after a loss. That and we talked about at the very beginning, when you walk into that new pregnancy, it's not possible to set aside the stress and the anxiety. So, one, how do you help, if a mom says, that experience was so stressful, so difficult. I can't conceive again. Like, I can't open the door to saying, like, that's possible again. So how do you help her move through those trauma cycles when she's triggered because of that? And then on the flip side, if a woman does choose to move forward to a pregnancy, how do you help her reconcile what she's about to go through, which may or may not be similar to the last time? So, two women, two different scenarios, but they start at the same place. One chooses a different path than the other. How do you help them both move through those particular cycles so that they are at peace at the end?
Absolutely. I think for the first one who decides, I can't do this again, this is for any number of reasons, a lot of that work starts with completely leaving the space for that choice to be real. And we're going to acknowledge and we're going to honor that this is what you're choosing. I think there's a lot of pressure from the outside world to go, no, it won't happen again. Just think positive. It'll be fine next time. Now you know, blah, blah, blah. And kind of going back to what you had said earlier, sometimes you know that somewhere deep inside you go, this is not what I want for myself, or this does not feel safe to me again, or I choose no. And that no has to be honored and
It's valid.
validated.
It's
It's
valid.
totally valid.
Yeah.
And it's a complete sentence in this scenario too. I don't want to do this again, period. And a lot of that initial work is me really showing them how they can hold that no with zero judgment from me, to have that different experience than what they're having with maybe other people in their life, and letting them really sit with that no. What does that feel like on a Wednesday? What does that feel like on a Saturday night? What does that feel like at work, right? Is it still there? Because sometimes it's not. And sometimes there's a little bit of waveriness and they go, but then I had this thought, or my sister had a baby shower and then I was like, oh. But we leave room for that because that's okay. And other times they come back and they go, yeah, it's still a hard no. Hard no, 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 no. Once we have an idea of what really feels right to you, because you have to choose this. I have no stake in the matter because it's your body, it's your family, it's your health. My job is to help guide you on the path that you know is right for you. Once we know that it's a no, then it's a lot of work focused on the there's a couple layers to that. One is what type of health issues have come up since that trauma, because that is the third leg that I've been alluding to, is the neuroendoimmune changes that happen in the body because of traumatic stress. So what is that? How else is it showing up? We really kind of get the lay of the land, and then we go, where are we headed? What's that address we're putting in the GPS for you? Where do you want to be? And that will help us decide the path of how we move forward. And a lot of this work is focused on re-accessing somatic memories of, if they say, I want peace, then what does peace even feel like anymore? Because they've forgotten. We've all forgotten. What is more familiar is emergencies and alarms and threat. And so we have to make that familiar again. Our body will never let us have what we want unless it is familiar, even if it's better for us than what we have right now. And so that's really where that work begins. For the second person who says, all right, here we go. I'm going to do this. I don't feel great about it, but here we go. That's the client who comes into the Path to Baby program. And we start, as I mentioned earlier, before they're ready to try to conceive, to start practicing this for exactly as you said earlier, is when it becomes familiar and it becomes a familiar muscle, then when you're back into that threat state of pregnancy, because that is what it will be, then you have a familiar muscle to rely on again. And our focus there is, a lot of it is completing those threat cycles from before. So we access a lot of somatic memories from the previous pregnancy. So for example, from my example of being on hospital bed rest and being in this bracing position and tight. Well, what came out of that? Shoulder pain, back pain, hip pain, tight pelvis, and so how do we complete that cycle that I couldn't complete back then, or in the NICU, right? The cycle of, I want to just grab him and take him home and make this all go away. How do we release? And actually, it's called using the survival stress as opposed to storing it or keeping it, freezing it inside. And so we start with that. And then we do another audit and we kind of go, okay, what health issues are you at risk for because of what happened in your previous pregnancy, because of maybe your preterm delivery, and because of the traumatic stress that you have been living with for these months or these years? Because that sets the stage for what you are at risk for in your next pregnancy. It's not just, I had preeclampsia before, and so now I'm at X% higher risk of preeclampsia next time. It's possibly more than that because the traumatic stress also elevates risk for pregnancy complications. So then we start rebuilding the team and we go, who's going to get that? Who's going to listen to you? Who's going to really give you a complete picture of what your care plan can look like, including addressing these neuroendoimmune changes that we will work on. And then slowly, as she gets pregnant, we start looking ahead and we go, okay, for example, women who I've worked with who've had early pregnancy bleeding. Well, that first trimester is terrifying.
Sure.
And so we do a lot of somatic memory work about sensations and what's that going to bring up and how do you move through and complete your cycle. The intention is never to stop being scared. And I realize that for some people, like, I don't want to feel scared, but you're going to.
But you're going
because
to.
You're going to.
Yeah.
Because in your previous pregnancy, look what happened. And here it's not just an experience or a phase of life. There's another life dependent on you. Of course, you're going to be protective of them. Of course. And that's really what the fear is. It's not a problematic experience. It is your protective nature that is coming up going, how do I keep this little being alive?
No, I'm so glad that you said that because I think sometimes, at least in our case, when we told people we were having another baby, one, there was a lot of judgment. Like, I can't believe that you're going to subject yourself to that again. But also that when I would voice fears or concerns, that people would be like, well, clearly you didn't do your homework. And I'm like, well, was I supposed to be completely okay? So this validation of course, like, and you said at the beginning, of course you are anxious. Of course you are concerned. And some of us decide that those things are worth it, that we're willing to go into that again, and some don't. And neither one of those is incorrect. They are both valid because your trauma is your trauma and you have to move through it however, best suits you and your family. So I'm really glad that you said that.
Yeah, I really believe it. And it just goes back to the very beginning of how we started this conversation of why I practice and work from a salutogenic approach. I do not believe in pathologizing a normal, expected experience. If you experienced your life being threatened, your child's life being threatened, or a loss of life, to then expect going to the same experience again and not being scared makes no logical sense.
Agree. Yeah. I agree. Okay. I love that you said that. Okay, so I just have one last question for you. I'm looking at the clock. I want to make sure that we're mindful of your time, but so I'm going to ask you to dream for just a minute. So like what kind of I always love this question. What kind of breakthroughs either in mental health or in trauma therapy do you hope to see in the next 10 to 15 years? Like what would be a place that you think that we could get to that we're not at right now, but that's possible and that could be a real boon not only to women but also, professionals that work with them.
Oh, I want a lot of things. I would start with what we just talked about, to stop pathologizing normal expected experiences for birthing people, partners, anybody around them. I would love to see the acceptance that trauma is not a mental health issue, but it is a whole body, whole health issue. And I hope that's come through in our conversation today. Like, just remember that car accident example. It wasn't an anxiety issue in the moment when the car was about to hit. It was a survival thing, and that survival thing affects every cell in your body. So we'd love to see that being addressed and approached appropriately. I would love to see a normalization of a salutogenic approach to chronic and traumatic stress. We just depathologize things. I would love that. And then I think my dreamiest dream is to have stress physiology centered in prenatal care across the board standardized for everybody. I think that's the missing piece of the puzzle here. I think it's going to make a humongous difference in pregnancy outcomes, fetal outcomes. And the day that happens will be a glorious day.
Well, I know that when our son was a NICU baby, they started basically like a centralized care, meaning that instead of going to 15 different doctor's offices and 15 different places in, where we live, instead it's like the comprehensive care clinic. Instead, you're going to come here, and if you need an MRI, if you need this, if you need a psychologist, like it was all in one place. And of course, it was for kids who were highly, medically complex. In other words, that their days and weeks could be completely transformed by this clinic. And I think what I'm hearing is a little bit of that approach to just in general when it comes to pregnancy is that comprehensive care, because it's not just the body that births the baby. It's not just, the head that thinks about all the things that you need to do. It's not just the heart that loves. Like it's a whole body experience of all those things. I'm on board with that dream. I'm with you. I think it could transform the stress, but it could also transform the experience, no matter what the outcome may be, that person is cared for from the beginning and to the end, which ultimately leads to better success. I mean, if we're going to talk about statistics, I have to think that they would skyrocket in all the best of ways if that was something that we. Oh, I like to dream a little bit. I love that you let me do that for a little bit with you. Parijat, you are one of my favorite guests to have. Thank you so much for sharing with our NICU professionals more about somatic trauma therapy and how it can really be a benefit both in their NICU as well as outside the NICU. So thank you.
Absolutely. Thank you so much for having me. You're one of my favorite podcasters to chat with as well.
Thank you. Thanks, y'all, for listening to NICU Heroes. If you enjoyed today's episode, please don't be shy, y'all. You can share it, you can subscribe, and you can most certainly review it. We would love your reviews. It's how we reach more NICU professionals. I'll see y'all next time.